जी, अस्सलाम वालेकुम. First of all, I introduce myself. I am Dr. मोहम्मद सतवर शेख, representing Pharmevo. और आज इस वर्कशॉप में आपको खुशामदीद कहते हैं. आज की वर्कशॉप का बेसिकली जो ऑब्जेक्टिव है दैट इज डेमोस्टिफाइंग द ऑर्थोपेडिक सर्जरी. और दिस इज ऑनलाइन वर्कशॉप एंड इसका कोर ऑब्जेक्टिव और कोर सिनेरियो में आप लोगों को बताता चलूं कि इसमें हमने जो टॉपिक डिसाइड किया है वो टॉपिक है इज इट सेफ टू रिज्यूम इलेक्टिव ऑर्थोपेडिक सर्जरी फॉलोइंग द कोविड-19 पैंडेमिक. इसको होस्ट मैं कर रहा हूं और हमारे पास फैसिलिटेटर हैं स्पीकर Dr. Farooq Gilani Sahab. Dr. Farooq Gilani is an consultant orthopedic surgeon working in Mukhtar A. Sheikh Hospital, Multan. After that, we have expert panel. In expert panel, we have Professor Dr. Khalil Ahmed Gill, consultant orthopedic surgeon, as well as ex-HOD orthopedic, Nishtar Medical University Hospital, Multan. Second expert panel, where we have Professor Dr. Mohammad Kamran Siddiqui. He's HOD of Orthopedic, Nishtar Medical University Hospital, Multan. Last but not the least, we have Dr. Awad Ahmed. He's Assistant Professor and Consultant Orthopedic Surgeon in Nishtar Medical University Hospital, Multan. So this is all about the introduction of today's workshop. And now I would like to call upon the speaker, Dr. Farooq Gilani. Sir, kindly share your screen and start the presentation.
Sure. Assalamualaikum. Can you hear me?
Yes, sir. We are hearing you.
Thank you very much for organizing this session, and I'm very thankful to all the expert panel, Dr. Khalil Ahmed Gill, Dr. Kamran Siddiqui, and Dr. Awad Ahmed, who took time to participate in this sort of debate. I think this is very related to the current situation. We know the pandemic, COVID-19 pandemic is everywhere, and elective orthopedic surgery has stopped in almost all parts of the world. But we need to come up with some guidelines. So there have been some guidelines published all over the world, especially in Europe and USA. So I have collected some data, searched the literature, and I'm presenting these guidelines, which probably can be adopted by any surgical specialty. These are not just for orthopedic surgery. You can actually slightly modify them, and then you can apply it to general surgery, urology, plastic surgery, thoracic surgery, and everything. So let's start. Introduction. COVID-19 disease has rapidly progressed in the last few months. We all know that, and has been labeled as a pandemic by WHO in March 2020. There have been over 7 million cases all over the world and about 400,000 deaths. High infection rate has been found usually in smokers who have other comorbidities, especially cardiorespiratory diseases. Currently, there is no active vaccine or effective treatment for the condition. It's all symptomatic treatment, but many trials are going on. We can speculate that COVID-19 will stay with us for a long time. We don't know for how long. So we have to learn to live with this virus. Containment procedures are being taken everywhere, all over the world, both by the patients as well as the healthcare professionals. This pandemic has caused a disruption of the healthcare activities, whether it's a government healthcare activity or it's a private health facility. All are being affected by this pandemic. This halt in the elective orthopedic surgery has caused a huge impact, not only in the private sector, but also in the government sectors. Now, this is a graph showing the rapid progress of COVID-19 cases in Pakistan. We know that there were very few cases in about May this year, but now the cases are more than 100,000 in Pakistan, and we don't know how far this graph will further go. This is a graph showing the recoveries as well as the deaths in Pakistan. The green line shows, yes, it's positive that most of the patients who get the infection do recover. Death rate is low, but if you look at it closely, it's slowly getting up. Now, the guidelines I'm going to present is that we have to analyze the local COVID-19 data and then compare it with the patients, the elective orthopedic patients, and then plan how to proceed further. So for any area in Pakistan, the plan is you analyze the patients who have COVID-19 infection, their demographics, their comorbidities, HDU or ICU admissions, mortality and discharge rates. Then you gather that data and you compare that data to the people who are waiting for elective orthopedic surgery. And you compare how much is the difference between the two groups, those who had the infection and those who are waiting for surgery. You can divide them into low risk groups, moderate risk groups, and the high risk groups, depending on their symptoms, results of the tests, and local COVID-19 data. After matching the two groups, you can actually predict which groups will have more complications and which groups will have less complications if we go ahead with elective orthopedic surgery. So we classify the elective orthopedic procedures into day cases, short inpatient stays, which are one night stay, and long inpatient stays, which are usually about a week, especially those patients who might need HDU or ICU admissions. After analyzing the data from the patients and the elective patients waiting for surgery, you have to analyze your resources in the hospital. Do you have everything available to cope with all those patients? Uh, we propose that there should be daily multidisciplinary team meetings that should involve surgeons, anesthetists, theatre staff, and management to plan the patient admission, theatre utilization, post-op care, and discharge planning. Theatres should be deeply cleaned at the end of every day, and all the necessary PPEs should be available to the staff working in operation theatres. Uh, there should be dedicated and well-trained teams working in the pre-op, intra-op, and post-op areas, and they should coordinate with each other very closely. The team should stay in their designated areas to prevent any cross-contamination. And all the staff should be tested for COVID-19 prior to starting any elective work. We know that we do check the patients whether they are COVID-19 positive or negative before any elective surgery. But at the same time, it's important to check the staff. If they have any symptoms, they should be swabbed with a PCR. Antibody test can be offered if it's available, but as long as the PCR is done, I think that should be okay. Now, before proceeding further, pre-op assessment, we have a pre-op clinic where the anesthetist assess the patients pre-operatively to make sure they are fit to proceed for surgery. We should design a pre-operative questionnaire that should be filled in by the anesthetist. If everything is seems to be okay, then I think it can be done on the telemedicine. Many hospitals have switched to telemedicine these days. We have been doing telemedicine since the pandemic. So if the patient is not high risk, the anesthetist can actually just fill in the questionnaire on the telephone, unless there is a reason for a face-to-face encounter. In that case, the patient may have to attend the pre-op clinic. All the laboratory and radiological investigations should also be checked on the telemedicine using the HIM system, which is the computer-based system, at least 5 days prior to surgery. At the same time, MRSA and MSSA swabs should be taken 5 days prior to surgery, and all the patients undergoing surgery should have a thorough body wash with antibacterial body wash preoperatively and postoperatively. All the patients who attend the pre-op clinic, they should be provided adequate information about their post-op rehabilitation. Uh, they should meet a physiotherapist who will guide them through the leaflets and the videos so they can actually recover quickly post-operatively and can discharge sooner than later. So then COVID-19 screening, again, there should be a questionnaire for COVID-19 screening, should be performed in all the patients prior to surgery. It should be done at least within 5 days of surgery. Uh, then this questionnaire should be repeated 48 hours before surgery, because we know if the patient was negative a week ago, there's a chance he may contract infection from someone. Because we know the incubation period of COVID-19 is about 5 to 6 days, but it can be up to 14 days. So repeat the questionnaire for COVID-19 48 hours before surgery. And depending on that questionnaire, we will decide whether the patient can proceed with surgery or not. So JBGS has listed the clinical symptoms in about 4,000 patients. The most common symptoms are fever, fatigue, sputum, muscle aches, and the less common symptoms are GI symptoms, dyspnea, sore throat, headache, and upper respiratory symptoms. Now, while we're resuming the activities, elective orthopedic activities, we should set some priorities which should not be compromised uh, in the hospital for the patient as well as for the healthcare professionals. COVID-19 screening should be done for all the staff who are working in theaters alongside with the patients. Adequate staffing is very necessary. I mean, adequate staffing means everyone is available to do their job. It shouldn't be overcrowded, but it shouldn't be short of staff either. The most important thing is to assess the mental and physical well-being of the frontline staff. We know that it's a very tense job to work with the COVID positive or negative patients or suspected COVID patients. So the hospital should organize something to have a continuous assessment, mental and physical assessment of the healthcare workers. The theater should be cleaned immediately after every case, and it should be deeply cleaned at the end of the day. Now we propose a phased return to elective orthopedic surgery, phase 1, phase 2, and phase 3. So phase 1 is when you include low-risk patients on your operating lists who can get maximum benefit from surgery. These usually incorporate day cases like knee arthroscopies. These could be done as a day cases, removal of metalworks. The patient should have any post-op x-rays performed on the same day before they discharge. These patients should have a 6 weeks follow-up on telemedicine just to make sure everything is okay. And a feedback form should be filled in regarding the service and the outcome of surgery. If at any stage during those 6 weeks post-operatively, the patients run into any problem, then a face-to-face appointment should be booked without any delay. Now, after we have successfully completed phase 1 and we know that we are doing well, we move to phase 2. Phase 2 involves medium risk patients with short inpatient stay, 1 night stay, 2 night stay, like ACL reconstructions, fracture fixations, non-union fracture healings, things like that. These patients should get fast rehabilitation after the surgery and should have radiographs within 24 to 48 hours of surgery on the same admission before they discharge. Again, a 6 weeks telemedicine appointment should be booked for these patients and a feedback form should be filled in. Again, if at any stage the patient has any concerns or contacts the hospital about an issue which cannot be sorted on the telemedicine, a face-to-face appointment with the surgeon should be booked. After completing phase 1 and phase 2, then we move to phase 3, which includes all the complex orthopedic surgery and should focus on return to all elective procedures, including complex joint replacements, revisions, and things like that. Patients requiring HDU, ICU admissions should also be included in this group, and they should be encouraged to mobilize early to get early discharge. Again, 6 weeks follow-up on telemedicine. Unless there's a problem, then patients should come back and have a face-to-face consultation with the surgeon. So these are the phases in which we think if we move step by step, we will know where we stand and how far we can proceed further. Some general guidelines for everyone who works in the hospital. So for elective patients, whenever possible, regional anesthesia should be preferred as compared to the general anesthesia. If the pandemic situation escalates at any stage, we can halt elective orthopedic surgery. No matter we are in phase 1, phase 2, or phase 3, we can stop there until the situation gets better and we can restart again. Reinstatement of the elective orthopedic service should also include availability of face-to-face clinics, which means that we're not totally depending on the telemedicine. We also have clinics which are working full-time. So if a patient needs to attend, they will have to attend and see the surgeon or anesthetist. Similarly, medical optimization of the patients, preoperative planning, and multidisciplinary team decisions should be taken in these meetings for these complex cases, but there should not be any compromise on the provision of best quality services to the patients. We know that ASA grading is useful for elective surgery, ASA grade 1 to 5. But I think with this COVID-19 pandemic, there are some other factors which should be considered by the anesthetists before proceeding for elective surgery. Now, in the future, we should have some more guidelines to add COVID-19 infection on the consent form. Because at the moment, we know for every orthopedic procedure, we do ask patients to sign a consent form. But I think after this pandemic, we will learn many new things. And COVID-19 infection could be a potential complication of surgery, which maybe in future has to be added on the consent forms. Infection control team of the hospital is very important to make sure all the turning and doffing is done properly, and they should be kept involved at all the times. Hand washing, again, we cannot say more about it. The timing should be at least 20 seconds. The temperature of the water is not important, and this has been proved by many studies, but the timing is important. So to make sure that all the healthcare professionals wash their hands time and again. Several adaptations I think we will have to take in operation theaters, like social distancing, wearing the masks all the time, not to touch your face, your nose, your eyes whenever you are in operation theater. We know that many places the masks are only worn during the procedure, not in the other parts of the operation theater. But I think in the future that may have to make our habit to wear the masks all the time. MDT approach is very important while returning to elective orthopedic surgery. While we're in the transition period before like starting phase 1, I think we should have MDTs every day. It should involve surgeons, anesthetists, management, and housekeeping staff. These meetings should be on daily basis to discuss all the important issues that we can come across during and after the surgery. Once we successfully pass through phase 1 and we are in phase 2 or 3, I think we can reduce the frequency of these MDT meetings to maybe once a week or twice a week to make sure that everything is safe to proceed. MDT meeting should also review the complications along with mortality and morbidity after these elective cases. So in summary, this guidance is three-phase process, phase 1, 2, and 3, starting from smaller surgeries and stepwise pattern going up towards more complex and complicated surgeries. This is all evidence-based from the literature and can be implemented by any surgical specialty, and any hospital can actually make their own guidelines depending on their circumstances. All healthcare professionals who are at the senior levels, they should be very supportive and responsible to provide all the necessary things which are needed to provide safe and quality care to the patients. In the end, there are just some references from where all this presentation has been taken. The many guidelines from the BOA, British Orthopaedic Association, also guidelines from some of the NHS trusts, and also as some guidelines from USA. And basically that's it. Thank you very much.
Thank you very much, Roxab, for such an informative session. And now we are open for question answer session. I would request to all the audience, they may ask any questions regarding the presentation or regarding elective orthopedic surgery, whatever whatever the question is. We have, as I told, we have our expert panel. So kindly ask question. You can also write your question in chat box, as well as directly ask question by unmuting yourself.
So any
या लोग ज्यादा नहीं है, या लगता है इंटरेस्टेड नहीं है, या हमारे से ज्यादा नॉलेजेबल है?
Okay.
Can I ask? Can I say something, please?
Yes, Sakib Javed sir, please.
Assalamu alaikum to all the members. My name is Sakib Javed. I'm Dr. Gilani's classmate from Mr. Medical College. I'm currently working as a final year SPR in urology in the UK. Obviously, orthopedics is not my specialty, but I joined the session just to kind of see what was being discussed. I think I don't have any questions, but just a comment. What Dr. Gilani has said is more or less what is being practiced here in the UK, preoperatively, intraoperatively, and postoperatively in almost every specialty. In the last 3 months or so, we, in more or less every surgical specialty, we have not done major surgeries just because of the risk of COVID-19, especially in high-risk patients who are diabetic, who are immunocompromised. Obviously, if it comes to some major cancer surgery, then we have to make some decision and explain the risk to the patients and operate on them. But gradually things are improving. We did our first major case in our hospital on Monday, which was a radical nephrectomy after almost after 3 months in which I was involved. But I think overall the guidelines which Farooq Gilani has kind of kindly discussed is more or less what is being practiced all over the UK. I know sometimes it's difficult for to implement these international guidelines to your local hospital resources का issue होता है, और आपके patient cohort का भी issue होता है, उनकी education, उनकी understanding. There's a lot on social media coming out these days. लोगों को I think awareness की ज़रूरत है, education की ज़रूरत है. So just a recommendation के like these sessions for doctors. Doctors and hospitals should organize sessions for awareness, patient awareness as well. Because at the end of the day, ठीक है, हम as doctors we know what we are faced with, but patient cohort जो है, even आपको बाज़ दफ़ा में, I'm sorry to say this, but आपके घर में जो लोग हैं उनको भी convince करने में problem हो रही होती है कि COVID is a reality. So I think it's all about patient awareness and making sure कि लोगों को पता है कि हम what are we trying to what are we faced with here. So thank you very much. I'm thankful for the opportunity given by the pharmacological company who organized this. So I wish you all best of luck. Thank you very much.
Thank you, sir. Thank you. Ji, any questions from any side? Okay. इसके बाद आई थिंक क्वेश्चन है नहीं, तो हम चलते हैं अपने एक्सपर्ट पैनल की तरफ, फाइनल रिव्यू लेने, फाइनल नोट लेने. तो स्टार्ट करता हूं डॉक्टर खलील अहमद गिल साहब से. डॉक्टर साहब, आप अपने कुछ इसमें कंक्लूजन रिमार्क्स देना चाहेंगे रिगार्डिंग जो हमारा टॉपिक है इलेक्टिव सर्जरी फॉलोइंग कोविड-19. तो इज इट सेफ, और आप इसमें क्या अपने पॉइंट सेट करना चाहेंगे?
हाँ जी, थैंक यू वेरी मच. आपने ये हमारी मीटिंग अरेंज की, एंड आई वाज काइंड ऑफ वेरी हैप्पी टू जॉइन our colleagues on webinar, and we are thankful to you. And again, thankful to Farooq Gilani that he has updated us from the international literature from the UK and USA. And I'm happy to know a lot of questions which have been answered in his talk. But I would say is in our limited resources in our setup, like sitting in Multan, the basic emphasis we should be giving is the fitness of the patient beforehand. We should be dealing with the patients and assessing them more comprehensively, so that anything which are like uncontrolled diabetes, asthma, other cardiac issues for which the patient is taking medicine, for these patients should be separated from the very fit patients who are kind of coming from for elective surgery of a medium scale, as he said, phase 2 type patients who are going to stay for 1 day here. So after screening them in the labs and also in their history, we can select the patients for this procedure. Obviously, this heart cannot be forever, and it's already 2.5 months, and now the people are coming, and the patients are demanding for this kind of surgeries to be opened. And I think that it would be rather safe if we should not rush at the surgery. Once we decide and plan for the patient, we should 4 or 5 days or a week before the surgery, we should be putting him through the exercise of questionnaire and assessing him and ruling out any kind of symptoms which the COVID-19 common symptoms are there. And secondly, the team which is operating on these patients should be very much clear-headed, and they should themselves be healthy, and the adequate staff should be there. It shouldn't be overworked, or anything cannot be compromised on the cleanliness or on the procedure which is acting over there. So the team which is operating must be full and healthy to take up those cases. And the third important thing which I mean really is the multidisciplinary approach and team. And we should be involving anesthetist, cardiologist, physician, and the administration staff in the meeting, which would be, assessing the patients beforehand, before the surgery. So these things should be practically, we have to opt nowadays because COVID-19 is going to stay there and we have to modify ourselves. So these things should be coming in routine, and then we can go ahead step by step from the shorter surgeries, phase 1, phase 2, and then we can head on to the phase 3 surgery. And then at the end, I would have a query from Farooq Gulani, that if he has gone through any literature showing the activity of the disease after surgery in any kind of patients, or morbidity which is directly related, in the operated patient. Has he seen any paper or any, kind of study which has gone in which the morbidity has been shown specifically for the COVID-19 patient?
Dr. Farooq, are you cleared regarding the question?
Yes, what I understood was that the question was कि जो COVID-19 के patients हैं, वो जिनमें comorbidities भी हैं, क्या उनमें किसी किस्म की increased complication rate या increased post-op complication इस तरह से note किया है या नहीं? Is it correct?
Yes.
So exactly ऐसा की है खलील साहब के for the time being हम COVID-19 पे operate नहीं कर रहे, तो कोई भी नहीं कर रहा COVID-19 पे. So और जो हमारे ये phases हैं, our plan is still कि जो phases 1, 2, 3 हैं, इसमें जब COVID-19 का positive patient negative हो जाएगा तब ही हम सर्जरी में proceed करेंगे. So अभी तक ऐसा पर्सनल मेरा कोई एक्सपीरियंस नहीं है कि जो पेशेंट पहले पॉजिटिव हुआ हो फिर नेगेटिव हुआ हो उस पर ऑपरेट करेंगे, तो उसके बाद ही पता चलेगा कि क्या उसमें अगर एक दफ़ा पॉजिटिव हो चुका था, ऑफ कोर्स वो बाद में नेगेटिव भी हुआ, लेकिन क्या उसमें री इन्फेक्शन पोस्ट ऑपरेटिव भी डेवलप हुआ या नहीं हुआ, या उसको कोई और कॉम्प्लिकेशन डेवलप हुई जो नॉर्मली या रूटीन में लोगों को डेवलप नहीं होती.
Exactly.
इस तरह का इस तरह का अभी तक आई हैवंट कम अक्रॉस एनी पेशेंट. But regarding literature, I will search for something. If I find something, I will definitely let you know. लेकिन अभी तक मुझे ऐसा literature में, क्योंकि I think literature will also take some time to come about this thing, कि अगर आप COVID-19 patients में operate करते हैं या वो लोग जो negative होते हैं after positivity उनमें operate करते हैं, तो आगे उनकी outcome कैसी होती है. I think we may have to wait a little bit before the literature comes out on this, but I will search for something, and if I find, I'll definitely let you know.
Thank you so much.
Thank you.
Thank you, Dr. Farooq and Dr. Khalil Ahmed Gil Sahab. Now I would request to Professor Dr. M. Kamran Siddiqui. Sir, please, would you have some words on the topic?
Bismillahirrahmanirrahim. It was a very fruitful talk by Dr. Farooq Gilani and valuable comments by Professor Khalil Gil Sahab and the other participants. And definitely we are facing a situation in which we have never faced before. Even the whole world didn't know about it. And still, if I'm right, we still do not know exactly what to do in future. We are still planning things which were different 3 months ago, when we thought that this lockdown may last for a few weeks. And now about 3 months have passed and we are still not sure that what will be the duration of the so-called lockdown or restriction of our medical activities to otherwise healthy and fit patients. So there is a dilemma to decide. We honestly have been doing some elective surgeries in Nishtar because of some pressures. I mean, we have not been doing the joint replacements and the arthroscopies, but we were doing some elective cases because of the patients were waiting for so long. And now, since the lockdown has been eased out, probably we will be doing a bit more. But the question remains that the risk of proceeding or delaying, we have to seek a balance in between the two. That is, we cannot make a patient to wait so long for a non-union of the femur. He has been waiting for the last 1 year. He was on our waiting list. But I thoroughly agree with Dr. Farooq Gilani and Professor Khalil Gilsab that we have to be very vigilant. There should be a teamwork. We should involve the anesthetist, ASA grading, and all the other prerequisites. We should not induce something bad in the patient. I mean, patient and especially the attendants. You know, our culture that one patient, 5 attendants, they are all exposed to our environment, which may be fruitful for contacting COVID. So it is also the teaching and the training of the attendants also. They should also have feel the risk of going to the hospital and contacting this dreadful disease. So we have to teach the patients as well as the attendants, and at the same time we have to see the burden of the eased lockdown, and we may have to increase our so-called elective list a bit. We had reduced our burden to about 50% or so, but I'm sure that in the coming days we'll have to increase that numbers also. And what about the routine testing? I mean, we have been discussing a lot that every patient which got to be operated, has to be operated for an elective procedure, should get COVID-19 tested. I don't know what is the status of these ethical issues regarding this routine testing, because in the West, there have been issues regarding the ethical testing of HBS and HBC, we all know, and HIV. If the patient does not offer and is not willing for these tests, we cannot do those tests. So I don't know what is the practice in the West. Are they getting the routine testing of those going for these elective procedures, or they are waiting for the patient's will, or because we have to operate every patient considering that is potentially, as we consider that it's HIV positive, so we otherwise. That is the best way, because there is 30 to 40% risk of negative tests also in the positive patients. So all these factors we have to weigh and balance, that we may be operating a patient which is COVID-19 tested negative, but he may well be positive, because he may be in that category which is otherwise positive but not being tested positive because of the lack of the availability of the proper test at this stage. So I think these are all the factors which will take in the consideration, and this is a fluid state. What we are saying today may not be valid about 2 weeks afterwards because of the changing situation. So we have to, I think we should continue to remain in touch with each other, and it will be a good thing if we have a similar meeting about a couple of weeks afterwards, so we can reassess the situation, because as far as whatever the available data suggests to us. So we have to remain on our toes. So find what are the risks. We do not want to infect our team and ourselves, but at the same time, we should be able to provide some good to the society. So I think good luck to the doctors and to the community. But the my message is that we should train the attendants. Attendants are the very big risk factors in our community. If they do not understand what COVID is, and we have to teach them, there's no other way out. Thank you, Dr. Farooq, for very good nice meeting, and Professor Khalil Gilsab, very nice comments. Thank you, sir.
Thank you.
Very, thank you, sir. Thank you, sir. Very well said regarding the current situation and the elective surgery. Now, I would request to Dr. Awad Ahmed. Sir, please have some words regarding the topic.
Bismillahirrahmanirrahim. Assalamu alaikum. I totally agree with Farooq about the precautions, and Gilsab has very nicely highlighted all the things and problems related to what we are facing. And Dr. Kamran has made two valid points. The situation is valid. It's now 6 months since COVID-19 was first encountered, and we are still finding out what are its implications, what are its presentation, and how it affects the body. It's really a very wide spectrum of things coming out. So it's really nice to know the implications. The other point Dr. Kamran highlighted was that we need to have mass education of the people. When we go out into the city, you think everybody is loose and as if they have just come out of the confinement, and they don't in Pakistan, in our city, people are very much skeptical about whether it is there or not. So that is why the number of cases have jumped so dramatically in just 10 days, from 22,000 to more than a lakh. So we need to educate our population and we need to be very careful. And I am sorry to announce that one of my roommates died last night just because of it, and it took only 2 days. He had difficulty in breathing on 8th May, and he's now dead last night, and his janaza was just offered an hour before. So it is coming to our houses also, and people need to be very serious about it. And it is not prudent to be operating on the COVID patient, because theater is a confined space and everybody is worried about it getting the maximum load of virus through that. And a lot of doctors are getting infected as well as the general population. So we need to be very careful. And unfortunately, we don't have the required amount of tests available for us. So only people we think may have the symptoms, they are tested, not the general population. So we are not sure how many untested carriers are running around in the city. And this COVID-19 is here, and I think it is going to be here by the end of this year, and we have to be very careful about it. So I thank Dr. Farooq to give us an opportunity to share our thoughts and share his research regarding how to go about planning for needy patients, because we orthopedic specialty is such that we have patients who need to be operated upon. We can't wait on them, we can't sit on them, and it has very grave consequences for them. So only the elective surgeries which can be postponed, but the trauma which is not reducing in its magnitude, they need to be operated, and that is the major area of concern for us. Thank you all for being here. I thank Professor Khalil Saab, Kamran Saab, and Dr. Farooq, who is a close friend, for being here and sharing their thoughts with us. Thank you all.
Thank you.
Thank you very much, sir, for your kind words. And now this is time to say a goodbye with the note of thanks. Sir, once again, I would like to pay a great thanks to Dr. Farooq Gilani Saab and our expert panel, Dr. Khalil Ahmed Gill, Dr. Kamran Siddiqui, and Dr. Awad Ahmed. Sir, thank you very much for you all. And last but not the least, I would like to say thanks to our audience and the participants. Now we are ending our session. Thank you very much.
Thank you. Thank you.
Thank you. Thank you. Thank you, Farooq.